Good afternoon. It is so fun to be able to scroll through the gallery and see all your faces. As you know, this is President Kim welcoming you to Rotary on this first day of April, where there is sobering news on the projected impact of the pandemic. However, as always, there are reasons to be hopeful. It is spring. It's daylight savings time. And the birds in my neighborhood are singing early in the morning, which I love. I hope they are in yours as well. Plus, we are here together as Seattle Rotarians in the same way that we have been for 110 years. Today's program celebrates this hopefulness, beginning with an inspiration by Father Steve Sundberg. Father Steve.
Thank you very much. Could I ask everyone to just pause for a moment? I'm going to read a prayer in a moment that's called Pandemic, and it's from a Unitarian tradition by a woman named Lynn Ungar. And it would be helpful for us if we just take a moment, maybe just to, in the quiet of ourselves, think about what of the dimension of the pandemic is most pressing our hearts that we would like to hold up and get strength for. And then let me just read this prayer. Pandemic by Lynn Ungar. What if you thought of it as the Jews considered the Sabbath, the most sacred of times? Cease from travel, cease from buying and selling, give up just for now on trying to make the world different than it is. Sing, pray, touch only those to whom you commit your life. Center down. And when your body has become still, reach out with your heart. Know that we are connected in ways that are terrifying and beautiful. You could hardly deny that now. Know that our lives are in one another's hands. Surely that has come clear. Do not reach out your hands, reach out your heart, reach out your words, reach out all the tendrils of compassion that move invisibly where we cannot touch. Promise this world your love, for better or for worse, in sickness and in health, so long as we shall live. Amen.
One of our newest Rotarians, Christy Chen, will talk about her collaboration to bring much needed masks to local hospitals. The campaign is called #MasksForWashington, and its target recipients are the largest frontline healthcare institutions in our community.
Okay, so I want to start updating why we start doing this. So on March 21st, 3 Seattle entrepreneurs and myself that we decided to set up this GoFundMe campaign because we have this connection with Chinese 2 mask suppliers. They each specialize in KN95 masks, which all those frontline healthcare workers needed the most, and another one specializes in surgical masks. And they have international trade business, so they can get those to us in 3 to 5 business days, which is the fastest so far as we know. So we started this campaign on GoFundMe. We posted on all our social media. We reached out to UW Medicine, Swedish Hospital, and Seattle Children, and we set them as our pipeline hospital, saying that we would devote the first shipments to them. And on 5 days later, on 26th, we delivered 10,000 masks to UW Medical, and also one of the organizers owns a coffee company, so he donated 5 cans of coffee, and we distributed all those on that day. And on this Monday, that is 9 days after we first started this, we delivered our second shipment, which are 3,000 masks to Swedish Hospital, 4,000 to Seattle Children, and 2,000 more to Valley Medical in Renton. And now we're expecting our third shipment to come. And in our third shipment, we also helped Rotary, our club, to procure some masks, and also Seattle Fire Foundations, because they're giving this to the firefighters, which is so meaningful to me. And then because of our campaign, more surgeons and nurses write to our emails. They are coming from Tacoma, Puyallup, and all those smaller hospitals, they're saying that they don't have enough masks. And also they are nurses who are in direct contact with cold symptoms patients do not have masks. So they wanted more. So I hope that our Rotarian members can read about our campaign, including all our donation details on our website. So if you type www.masks4wa.org, and it will redirect you to the GoFundMe site. And then if you could donate any amount or even share it among your networks, that would be great. Okay, I'm finished.
Thank you, Christy. And it is so heartwarming to see your engagement in our community as a new Rotarian. We're very proud of you.
Thank you so much. Thank you.
You're so welcome. We thank you. Great work by Rotarians Carl Agee and Liam Lee will also bring masks to our community. We will share more about that next week. And if you are seeking an activity to stay engaged, please consider joining us in calling fellow Rotarians for virtual coffee, the same kind of conversation that you might have at a Rotary meeting. Contact Alicia Flatt, or find her information in the totem. Or if you'd like to help Harvest Against Hunger, feed our neighbors. There are packing opportunities. Several details in the totem, which is now a vital means of communication. Please read it. Now to our main program, Dr. Ann Marie Kimball, Professor Emeritus, Epidemiology at the University of Washington School of Public Health. During her tenure at UW, Dr. Kimball founded and directed the Asia Pacific Economic Cooperation, APEC, Emerging Infectious Network, where she led research and training programs. Her work focused on global trade and emerging infections and earned 2 awards, a Fulbright New Century Scholar Award and a Guggenheim Scholars Award.
Great. Okay, well, I'm delighted to be here with my fellow Rotarians. We from Bainbridge Rotary send our greetings to you. As you know, I was part of your membership for about 22 years. What I'm going to talk about today is the COVID-19 outbreak, and I'll talk a little bit about the history, the immediate past. We'll talk about flattening the curve, a little bit about hospital stress, costs, and where are we going, which is very unclear. I'd also like to frame this in what we at Rotary are struggling with over here, and I'm sure you're having the same conversations over there. So let's get started. I'm going to try and keep my remarks to 15 minutes so that we have plenty of time for questions and answers. So the first thing I wanted to mention was that this is not the first emerging infection, and in fact, HIV/AIDS was, in modern times, the first pandemic that came from animals into humans and caused great destruction. This was from a chimpanzee in Africa back probably in the late 70s, early 80s, and first detected in the early 1980s, as we know. I'm not going to spend a lot of time on that, but I wanted to make the point that these spillover events with new pathogens have been recurring since we first saw AIDS. And that, in fact, is what motivated me and people like Tony Fauci and David Heyman. We were all very involved with HIV/AIDS, and our question to one another was, what comes next? And Mother Nature has given us an answer over time. We've had recurring events since 1997 from Asia. Specifically, we had the emergence of an avian influenza in Hong Kong with a 30% mortality, a small cluster. Nipah virus in Malaysia, which had a 40 to 70% mortality. And we had the emergence of SARS, which we've all heard a lot about, in 2003 with greater than a 10% mortality. And then we had the emergence of H1N1 influenza from pigs in Mexico, which caused a global pandemic. I also was motivated, if you will, to put together a book in 2006, which I would recommend, of course, which talks about the global express and how these microbes, which can't fly and can't swim, managed to transit in the human community through our trade and travel. But what I want to really focus on is this new challenge, which is really overwhelming a lot of our systems and impressing us again with how important it is to pay attention to these pandemics and to work very hard internationally to try and subdue them. So this is basically the timeline of when authorities in China first reported an unknown pneumonia in Wuhan, and that was at the end of December. These things always happen around holidays. Don't ask me why, but that's just a side. They had 44 cases by January 3rd, and by January 7th, they had identified a brand new coronavirus, isolated it, and published it for the international community by the 11th. It was associated with a seafood market in Wuhan, which is one of their live markets, which carries not only seafood, but also a variety of other animals. And those of you who have been to China know that Chinese palates prefer very fresh meats. So the outbreak was then declared a public health emergency of international concern by January 30th, and this was primarily because of Thailand and a number of other countries. It was beginning to spread very fast. And then by February 11th, we got the COVID-19 name, and March 11th, it became designated as a pandemic. So this is where we are today with 823,000 cases worldwide. You'll notice the little orange dots represent all the different countries of the world where this coronavirus is actively spreading, more than 40,000 deaths. I'm not going to spend a lot of time on the international outbreak, just to note that Rotary works internationally as well as domestically, and one of the things we're struggling with at Bainbridge is where do we invest our time and talents at this point, given our international reach as well as our domestic reach. So this was the question back when we first began to have cases in the United States. Which curve were we going to follow? You see on this graph what's happened in Italy, which has been very profoundly affected, especially in the north, as well as other countries. South Korea is of note down at the bottom in purple, and their difference in strategy was that they began very actively testing, and that's a key part of what we missed. So this is the United States history with COVID-19. January 21st, the first case was here, not in Seattle. In fact, it was up north of us and was hospitalized in the Providence Center. And this was a young 30-year-old male who had been to Wuhan. That was published in the New England Journal as a fast track because they also used remdesivir in treating this patient successfully. And so at that point, that Snohomish Health Department worked very hard to try and get all of the contacts of this individual, but we didn't understand exactly how contagious this was. And it's very likely that some contacts were missed. Local transmission was first noted in February 26th in California, and we had our first death in Seattle, King County on February 29th. So from that point to present, basically all of March has been community spread, not only in Seattle, but as we've heard in New York, in Florida, and in Michigan, and all across the country. So we have a very profound outbreak at this point in the United States. But I'd like to keep my remarks more local and talk a little bit about social distancing. We have all given up basically our First Amendment rights in the interest of the greater good. It's a profound sacrifice for the population of the United States, of which 80% are now in social distancing orders. And really, we're doing it for a common effort to try and vanquish this virus and reduce the morbidity and mortality. So this curve shows you basically the difference with and without social distancing of an epidemic curve. And what this means to us is under the red curve, you would see not only a profound sudden number of cases and morbidity and mortality of sick people and dying people, but you'd also see an overwhelmed healthcare system. And I think that was one of the primary concerns all over the country with why social distancing is being practiced, and very, very strongly here in Washington State. And the blue curve shows you a flattening of that curve, but also an extension, so that you don't have that incredible peak of morbidity and mortality, but you probably have a longer presence in the population of active transmission. So this was the question when the governor made his declaration, and this work comes from the Bellevue Institute for Disease Modeling. They were asking which curve is Washington State going to be following in this epidemic? And we're somewhere between 50% and 25% on this graph, if you look at the middle two lines, because we have a little over 4,000 cases at this point in our state. This is some of the parameters that they're following in advising the governor on how long social distancing needs to be in place. And they're tracking a number of things besides just COVID-19 cases. I mentioned earlier that South Korea had been very successful with broad-scale testing, because broad-scale testing would have allowed us to detect, as Tony Fauci says, how deep the penetrance into our population of this virus. We didn't have that tool. In fact, testing has been a major federal failure for a lot of different reasons that I won't go into, but we basically were flying blind for quite a while in the state of Washington, and virtually all the locales in the United States were as well. And I think that was one of the most damaging pieces of inaction that we saw going into this. Testing would have given you a very much more exact curve that you could follow in terms of social distancing, but instead they're looking at Facebook mobility and de-identified mobility data from cell phones to actually understand how much are we limiting our mobility. They're also following the reproductive rate of the epidemic, and that's a little complicated, but that means if you have one infected person, how many people is that person going to infect? How many new cases does one case generate? And we were up at about 2.7 when we started a couple of weeks ago, social distancing, and now we're down to about 1.4. I think what's important for us to do is to begin to ask our decision makers, what is your target? How long is this going to last? I wish I had a crystal ball to share right now with everyone, oh, it's going to be 6 weeks, it's going to be 6 months, whatever. But I think it's more disquieting to our population that we don't know. And I'm hopeful that April 6th, when the governor decides whether to extend or not his social distancing measures, we'll get more of an idea of how long we're going to be in the woods. This is a curve about hospital use, beds, ICUs, and ventilators. And this is from the Institute for Health Metrics and Evaluation here in Seattle. It's a global resource for all kinds of metrics, and they do very, very strong work. It's Chris Murray's shop. But you'll see under this curve, you'll notice a big pink area, and that's their sort of level of uncertainty curve. But what this does is allows you to project that by April 19th, we will be at the very peak of our hospital and bed use in Washington State. And we're actually doing pretty good right now in the ability to meet the curve as we anticipated moving forward. So that's some good news. If you looked, and you can certainly go to the IHME site and see the nationwide curves and the curves for New York, and you'll be very grateful that Washington has done the proactive planning that they have done, including the field hospitals. I wanted to talk a little bit about the cost of epidemics, because Kim mentioned in the introduction that we started working with APEC back in 1993, basically after they came to Seattle for their big meeting, and HIV/AIDS was moving into Asia. It was clear that the public health infrastructure in Asia was a lot weaker than it had been at the United States, and we were not successful with AIDS. So we reached out to APEC and began a conversation about emerging infections. And part of our discussion with them was the economic costs of these outbreaks, which are shown on these slides, which I won't drill down into each and every one. Suffice it to say that the total takeaway from these emergent events, which I've described previously, was about $80 billion, which is an enormous number, but it certainly is shy of the $2.2 trillion package that the Congress felt it was necessary to pass. And I don't know if you can see, I've got this slide, but this is the monthly jobless claims. And it gives you an indication of what the impact of our shutdown has had on our economy just to date, with 3 million applications for unemployment. We're going to have an enormous economic challenge. And the other thing about being very, very stringent on social distancing is we may be able to mitigate some of that profound economic damage that I think is already pretty much in the cards. I wanted to talk a little bit about prevention because there is some new, relatively new data that comes out, and this virus is very transmissible. I think that was the key thing that was understood through intelligence from China in late January and certainly profoundly in February, but wasn't taken entirely into account by the United States at that time. This virus is transmitted person to person through close contact and droplets, and it's very infectious. It's not quite as infectious as measles. It's about the same level of infectiousness as influenza. It also lives on surfaces. So I wanted to share this graphic, which shows you that it stays 3 days on stainless steel, 3 days on plastic, and 24 hours on cardboard and 4 hours on copper. I don't know, I guess that's for your pennies. But what this means is that all our work with using alcohol-based cleansing for materials around us to prevent infection, all of that is very important and very well indicated. The other question that's come forward, and I'm glad you guys have been busy on masks, because masks have been a key part. One of the biggest pieces of, let's see, a lack of performance, I would say, is assuring personal protective equipment for every frontline worker. And beyond that, considering how general population, even when we are doing social distancing, how do we handle going into crowds? And I want to make it clear that surgical grade and medical grade masks should definitely be prioritized for frontline workers. Our nurses and our doctors and other assistants in hospitals and clinic and first responders should be the first order of business. And to me, it's been amazing and shocking that our country hasn't been able to bring those stockpiles to bear effectively. But now the question is being brought forward about masks for the general public. And what we heard in the first sense was probably due to our supply shortage that they weren't being recommended. But I believe you're going to hear over the next day or two that non-surgical, non-medical masks will probably become much more prominent in our response. This is a picture actually from Japan, but I can tell you that Hong Kong, Singapore, and China all mandated masks very seriously as part of their social distancing response. The final thing I just wanted to cover is some of the research going on, and I won't go into a lot of detail here, but I showed you some of the models, and the modeling research is moving forward very fast to try and get a good endpoint for a number of social interventions and also for the epidemiologic spread of this outbreak. But we're also looking at therapies. There are more than 100 different therapies under research, many of them in China. And the WHO has announced a solidarity trial of at least 40 countries participating right now to look at 4 critical therapies, including remdesivir, which is the agent that we first used in Whatcom County. And the vaccine trials are moving ahead, and one of those, the most advanced one, is actually here in Seattle with an mRNA vaccine being done by the Kaiser Permanente Institute and Lisa Jackson's group. And happily, the first shot in that safety trial was put in an arm last week. So you're seeing unprecedented pace of scientific research around this outbreak. But what I wanted to, I'm going to get off of this, what I wanted to put forward as a point of discussion, because we are struggling with it here in Bainbridge, is the role of Rotary. I think the solidarity work that you guys are doing by calling one another and supporting your members, that's exactly the first thing that we've been doing too. But the broader question that comes forward is, we have a lot of needs in our own communities, and yet we also have an international reach. And as we watch the most developed country and the wealthiest country in the world struggle with this epidemic, it's also important to keep in mind that this epidemic is in every inhabited continent all around the world, with more than 200 countries reporting COVID-19 cases. So they're going to need our help as well. So with that, I'd like to close and invite any questions.
All right, first question is from Bob Wiley. What do you think about the approach being taken by Sweden?
You'd have to explain to me the approach being taken by Sweden.
All right, next question then is
I'm sorry.
I can't. Maybe Bob can add a little bit more. From Bill Hammond is, if we begin to use masks for additional social distancing, how long do they work for?
That's a good question. Basically, for population-based, if you're not in a situation where you're taking care of patients, you can certainly reuse your mask. So, you know, I use a mask when I go into crowded situations, and I use the same mask as long as it's not evidently dirty. Now, if you're in a medical situation and you're taking care of patients, you change that mask with every patient, obviously. But for general use, not that important.
All right, we've got another question from President Kim Moore. What are your thoughts on national stay-at-home policy to shorten the pandemic in the U.S.?
Well, I think it was great that we finally got a national stay-at-home policy. The policy, the guidelines that came in postcards to most Americans were for a 2-week social distancing exercise that's less stringent than what Washington State is doing and what New York is doing. And I think that's appropriate, because what you're seeing is the epidemic plays out locally. It's not like we have a national epidemic that goes from west to east. We're having different epidemics in every state. And so every state governor is stepping up and deciding with council how to handle the epidemic within their state.
All right, this keeps jumping around, so if I don't get your question in order, I'll come back to some of them. Let's see. Question from Dave Kraft. If everyone were wearing a mask, would the stay-at-home order be necessary?
That's a good question, and I don't know the data on that. I think there may be some more wiggle room to loosen that, but I really can't say. I'd have to go back and do a deep dive into the literature.
From Patrick Carter, what are your thoughts on the 100% cotton homemade masks?
Well, yeah, that's an interesting question. Now, the N95, just to explain, is the most desirable mask because it actually keeps out viruses. But in a general population use, you don't need to keep the viruses out. You just need to keep the aerosolized, spit and that sort of thing out. And it's certainly good enough for that. That's what you're trying to do. And then avoid your own projections of things when you cough or sneeze to other people.
All right, next question is, oh, hold on, just jumped around. So we've got a couple of questions on whether staying at home will actually lower the total number of cases, or will it just extend the time period during which they happen?
That's a good question too. I think it will lower the total number of cases, and I'll tell you why. Because by spreading it out, as you saw on that curve, what we allow public health to do is to begin to do what they do best. And that what you'll see when we spread it out like that is you'll begin to see little outbreaks that they can then individually investigate and do control work as we would have been able to do had we been able to test back in the day. So I think you'll see overall a decrease in cases, and you'll also see much more effective investigation and control from your public health authorities.
All right, question from Russ Taylor here. In an HBR article this month on the experience of Italy, one challenge mentioned was the need to convert the focus of hospitals from patient-centered to community-centered focus. Can you speak to the details on that shift?
I'm not sure exactly how to take that phrasing. I think what you saw in northern Italy was basically the hospitals were overwhelmed with cases, and that was very unfortunate in that they also saw a slight increase, an increase in their mortality rate, which goes along with having your health system saturated and not being able to provide care for everyone. So that's a very dire situation that you saw in Lombardy. That's exactly the situation that we're trying to avoid in Washington State. And projections are that New York City is at risk of having something similar. So hold on to your hats. We're in for a ride this couple of weeks to see where this all goes.
All right, next question is that they're saying now that people may have contracted COVID-19 but don't show symptoms. Can you speak to that?
Yeah, that's an interesting part. It is absolutely true that there's some proportion of transmission that happens in people who are infected and asymptomatic. The most infectious part is when you are symptomatic because you're coughing and sneezing, but there's some evidence that asymptomatic people in close contact can also transmit. So that's a problem. That's a big problem. And that's part of the reason why we need that testing, and we're ramping it up. If we'd had it at the first sense, we would have been much more effective in our control efforts.
All right, question from Robin now. Given the lifetime of the virus on various surfaces, how frequently do you recommend that we disinfect surfaces in our homes, especially when we are staying at home and limiting access by people outside our homes?
Well, if it's only you, then it's pretty much, however often you clean your house. Because as you put your finger on, really, you and your family members are probably already sharing your status, whether you're infected or not infected. And if you haven't gotten sick in 2 weeks, you're probably not infected. So, you clean as you clean. Whereas if you're in a place where others come in and touch things and use things, then you'd certainly want to clean those surfaces.
All right, question, going back up the list here now to get to those that I missed. Question from Paula. Can you talk about how we know how many people actually have the virus if we are not, per priority protocols, testing everyone who has symptoms?
Well, that's a good question, and it still remains somewhat an unknown. Seattle King County has launched a new surveillance testing program that will give us some answers to that. And you're seeing nationally that we're getting more and more of an understanding. We don't have a seroprevalence test, which is where you take a blood sample and understand if somebody has been infected in the past. We don't have that test yet. We only have the presence of the virus as a current infection. So there's still a ways to go in developing those diagnostic tests to really get a true idea of the prevalence. So what we know is kind of what you see. There's been profound testing in South Korea, so we can take some of that work and generalize it to our population based on their findings and do projections based on that.
Okay, another question on testing from Jevin. How can public health be more prepared for testing when the next virus hits?
Excellent question. I think as soon as the genome was published, which was back in the first week of January, CDC did begin creating a test. But we needed to be on emergency footing a lot more quickly. The FDA had some difficulties understanding its role in allowing other tests to come forward. Frankly, Seattle has greatly benefited from the University of Washington, which was one of the early developers of a test that was acceptable. And so we just need to take a look back and an after action after this is over and say exactly that. What can we do next time to make this go a lot quicker?
Okay, and real quick interjecting, we're at 12:45 now, and Ann Marie, I know that I promised we would have 15 minutes of questions for you. Are you okay with going a little bit longer to answer some more of these, or do you need to take off?
No, we can do about 5 more minutes.
5 more minutes, okay. Next question then is, what can we expect with a second wave and next fall?
I'm sure hoping there's not a second wave, but that's an excellent question. When the influenza epidemic came through in 1917 in Seattle, we had 3 waves. So good question. I don't know what you can expect. We don't know how long immunity lasts. If someone has been infected with this virus, are they protected for months? Are they protected for years? We'll do everything from the public health side to prevent that next wave, but that's an excellent question, and I don't think anybody knows.
Also along the lines of timelines and seasonality, from Jim Duncan, do you think that it will slow down in the summer like the regular flu?
I sure hope so. That would be great. We didn't learn anything from SARS because it didn't go through a full season. We were successful at the emergency control at the source with that outbreak back in 2003. So we never watched it over a full year season to see if it's seasonal or not. This is a coronavirus, and coronavirus is responsible for about 15% of the normal colds. Colds are more prevalent in the winter. There's a possibility this could be seasonal, and I sure hope so. That would be great. But there's no guarantee at this point.
All right, looking back at a question from Jimmy Collins, what would you suggest we do as individual Rotarians to share this information and better inform our spheres of influence? And he asked if it would be possible to get a copy of your slides.
Yeah, certainly you can use my slides however you want to. And yeah, I would suggest the best thing people can do is to track the epidemic through the public health site of Seattle King County, through the Centers for Disease Control. I'm working to track it through Kitsap County. We have a lot fewer cases right now than y'all do, but just keep your finger on the pulse of the epidemic and listen to the advice from public health, but also stay in touch with the people you love. And that's tough when we're all remote. You know, make those phone calls every day. I think that's going to be really important.
All right, one more question from Emily. It seems that the age distribution of affected severely ill has changed to include younger patients. Do you know why that is?
I don't know. I was on a grand rounds yesterday with Bellevue Hospital in New York and Singapore. And in fact, they are seeing a lot more younger people. Under 20 still seems to be relatively spared, but they're seeing a lot of 30s and 40s in their patient loads. So it does appear that there may have been a shift in the demographics of this virus, to be confirmed as we watch it play out.
All right, and let's have this be the last question from Virginia McKenzie. With all the cleaning and hand sanitizer use, are we at risk of making superbugs?
No, because we aren't using antibacterials. Superbugs are bacteria, and if we were using antibacterials as opposed to alcohol-based, that could be a concern. But we shouldn't be using antibacterials. We should be using alcohol-based solutions, and the CDC has a full list of those on its website, and I suggest very strongly you check those out.
Well, thank you so much, Ann Marie, for being here with us today and for answering our questions. Thank you, everybody who attended and asked questions. Kim, do you have some closing comments that you would like to make before we take off for the rest of our afternoon?
If you can hear me, what I wanted to say, Ann Marie, is that we really appreciate the fact that as a Rotarian of more than 25 years that you can talk to us about our role. And we're very grateful to be able to call on you at this time. In closing, again, thank you, Ann Marie. Let's give her a round of applause. All right. Rotarians continue to be highly engaged in our community during this pandemic. Both Seattle Rotary Service Foundation and the district are working to provide emergency support to our community. We will share more information as it becomes available. And I'd like to thank everyone for joining this online program. Next week, please join us for another online program where we will hear from past President Bill Center on survival of the fittest. It may surprise you. Please be safe, stay engaged. Our community and our fellow Rotarians need you. We are adjourned.